Hello, friends. So I'll be just giving a snippet overview on CKD and low platelet. So this is more physiological topic. So very often we have the context setting is very often we have CKD patients who come with low platelets. And in rounds, I was just asking my trainees whether low platelets can happen in CKD, and not many had a clarity as to whether low platelets per se can happen due to CKD. If it happens, what are the reasons? So this snippet review is more to encompass a little bit of a clarity, to have a clarity on, yes, thrombocytopenia can happen as part of CKD, and even the setting of low platelets can perpetuate and worsen the progression of CKD if there is a chronic kidney disease in progression. So it is a diabolical sort of a situation, which is important for training because we see a lot of CKD patients. It is imperative we understand that low platelets can be result of CKD itself, and low platelets can be an indicator of worsening CKD or progression of CKD. So this is what I wanted you to all have clarity. So I wish to acknowledge my colleague, Dr. Chaitra, who helped me develop this content. It's only two slides. It's a snippet review. So as I said, thrombocytopenia can perpetuate CKD, and in CKD patients, there can be thrombocytopenia. So when we look at why there can be low platelets in CKD, there are around five broad categories for intensivists to know. One is, of course, there is reduced production of platelets in patients with CKD. We look into why that reduced production happen. Obviously, most often it is because of the uremic toxins, which we'll talk about. Then in CKD patients, there is increased destruction of platelets, especially factoring in the etiology of CKD. Suppose there is a lupus patients, suppose there is a TTP patients, hemolytic, because there is increased destruction of platelets. The third one is platelets tend to get activated. The activated platelets is not a good thing. Platelets are generally are in a non-activated and activated state. When they become activated, they become like stars. They have this sort of a tentacles that come out pictorially, and these are not good, and they tend to perpetuate the sort of a thrombocytopenia. We'll look into that aspect. And CKD per se, the qualitatively, although there is thrombocytopenia, qualitatively platelet function also gets affected. There is platelet dysfunction, and there is a lot of endothelial dysfunction that happens, especially when CKDs are on dialysis. Because of the extracorporeal flow of the blood, there is endothelial damage that itself leads to thrombocytes. So these are the five broad categories. When we talk about why there is reduced production of platelets, it is because of the uremia having an effect on the bone marrow, which leads to reduced production of megakaryocytes, and there is thrombocytopenia. And because there is CKD, we know there are accumulation of a lot of different toxins because kidney is a purifying organ. This also has a inhibitory effect on the bone marrow, which leads to reduced production of platelets. And, and as we know in CKD, the erythropoietin levels are low. So because there is a reduced erythropoietin, many of the CKD patients have anemia. So the relative blood volume or the red cell volume comes down, and this is also reflected as thrombocytopenia. So when there is reduced production, it is fairly intuitive. It is the uremia and the other toxins on the bone marrow causing thrombocytopenia, and erythropoietin, which we all understand is low, causes relative reduction in the red blood cell volume, which is reflected as thrombocytopenia. And why increased destruction? Increased destruction is related to the etiological aspect of CKD. So especially when these patients are on heparin during dialysis, and there is activation of the platelet. Because as I said, activated platelets are bad. When platelets get activated, they get destroyed. And sometimes the presence of antibiotics, because there are antibiotics which can cause thrombocytopenia. Even simple BLI antibiotics like ceftazidime or piperacillin in some individuals can cause thrombocytopenia. And NSAIDs, if it is the cause of CKD, can lead to increased destruction of platelets. So when you talk about destruction, generally the activation of the platelets due to heparin, antibiotics, and NSAIDs lead to increased destruction. And when we talk about when there is activated platelets so when there is increase in the activated platelets, then there is more destruction, then thrombocytopenia sets in, especially when the etiology of CKD is the cause of activation of the platelets that typically happens in autoimmune conditions like lupus, hemolytic uremic syndrome, or thrombotic thrombocytopenic purpura. So, where platelets get activated because of the autoimmune mediation of a lot of different inflammatory mediators, there is activation of platelets and thrombocytopenia sets in. And it is shown that the half-life of the platelets gets shortened. As I said, qualitatively also platelets become dysfunctional. The half-life of the platelets gets shortened, which means the lifespan of the platelets is reduced in CKD. And the last but not the least is especially CKD patients when they're on dialysis, where there is extracorporeal flow of the blood, there is endothelial damage, as you can see, and there is a direct injury to the platelets because of this extracorporeal circulation and the endothelial damage, especially when patients are on dialysis. So, friends, CKD patients do have thrombocytopenia. These are all the etiological reasons. There is reduced production, increased destruction due to certain drugs, and activated platelets. The platelets, see, the normal platelets do not have tentacles or spicules like this. When platelets get activated because of the autoimmune reason, there a lot of destruction happens and there is thrombocytopenia. And generally, CKD, the platelets half-life becomes shortened, and qualitatively there is platelet dysfunction and extracorporeal surplus. So these are the causes. So when you have a chronic kidney disease with low platelets, these are all the etiological reasons as to why they have low platelets. And as I said, it is diabolical. Thrombocytopenia itself can lead to perpetuation of chronic kidney disease. So CKD on medical manage can progress because of low platelets. So bear that also in mind. Why does this happen? Because when there is thrombocytopenia, it is shown there is activation of certain T lymphocytes, especially CD14 and CD. And this activation of these lymphocytes due to thrombocytopenia that is present lead to endothelial damage. And this endothelial damage is known to cause activation of the platelets. As I said, the platelets, normal platelets look like this. When they get activated, activated platelets are bad, and this activated platelets is a reflection of a chronic inflammatory conditions which lead to perpetuation of CKD. So what does it do? When platelets get activated, there is aggregation or agglutination. So all the platelets get clumped. There is clumping of platelets, which leads to perpetuation of CKD. I'll tell you why that perpetuation of CKD happens. And activated platelets, because it's autoimmune mediated or whatever mediated, toxin mediated activation of platelets lead to a lot of inflammatory processes within the body. All the inflammatory cells like phagocytes or megakaryocytes and neutrophils, lymphocytes, macrophages, they all get activated. What does this do? Because there is clumping of platelets and activation of these lymphocytes, there is a lot of microthrombi that gets formed in the glomerulus. See, all these microthrombi forms in the glomeruli, and there is a glomerulosclerosis. There is a lot of sclerotic elements that tend to happen within the glomeruli, and there is a chronic inflammation within the kidney, and there is a lot of renal fibrosis. So all these changes typically leads to worsening of CKD because of the activated platelets. So CKD per se can cause thrombocytopenia, and the presence of thrombocytopenia with these activated platelets lead to inflammatory cascade, which leads to microthrombi, nephrosclerosis, or the tubular sclerosis, inflammatory changes, and fibrosis, renal fibrosis. All this leads to worsening of CKD. And as I said, activated platelets is an indication of cytokine, for a lot of inflammatory cytokine mediators that get produced, and there is a smoldering sort of a cytokine storm that tends to happen. And the activated platelets leads to release of lot of DAMPs, which is damage associated molecular proteins. And there is something called platelet derived extracellular vesicles. So the activated platelets produce DAMPs, which is damage associated molecular, and they also produce platelet derived extracellular vesicles. All this leads to damage to the kidneys. And generally, platelets do not have genetic material. They do not have DNA. They do not have RNA. But when the platelets get activated, they express messenger RNAs. And all this leads to injury of the renal tubules. So there is sort of all this inflammatory process, fibrosis, and phagocytic cells that tends to get infiltrated within the tubules, and the tubules get damaged. So this is the whole pathognomonic sort of a elements that tend to perpetuate the worsening of CKD when there is thrombocytopenia. So friends, summarily, the snippet was mainly to highlight that CKDs per se have low platelet due to reduced production, increased destruction, increase in the activation of the activated platelets get increased, and qualitatively there will be platelet dysfunction and endothelial damage due to dialysis. All this leads to low platelets. When there are low platelets, bear in mind there are activated platelets which lead to chronic inflammatory process, which causes further worsening of the kidney damage due to microthrombi formation, sclerosis, inflammatory process, fibrosis, and there is a tubular damage that tends to happen. So this is all I wanted to highlight. So that's about it, friends. So whenever you see a CKD, bear in mind all these processes are happening which leads to this problem. So request you all to submit your valuable work to Journal of Acute Care. Of course, visit my website to rehear to this lecture. Thank you. Thank you, Vinod.